Good morning, good afternoon, and good evening, esteemed professors, doctors, guests, colleagues, and participants from all over the world. Welcome to Mass Epidemic of Antimicrobial Resistance, an international webinar conducted by the International Pediatric Association. Uniting thousands of registrants from all over the world, this webinar discusses important issues of the hidden challenges and threat of antimicrobial resistance that persists worldwide. Before beginning today's webinar, we would like to inform you of the rundown of this webinar. We will begin with a welcoming address from the President-elect of the International Pediatric Association. Then we will have the presentations from our distinguished panel of experts, moderated by our esteemed moderators. There will be a question and answer session with our speakers at the end of the webinar. For the smooth running of today's event, kindly pay attention to the following rules and regulations. Participants are encouraged to have their videos turned on throughout the webinar. Participants should keep their microphones off unless permitted by the moderators. And to obtain the certificate of attendance, participants are required to enter the entire duration of the webinar and fill in a feedback form which will be distributed at the end of the event. To officially open the webinar, we will now respectfully invite our first speaker to deliver the opening remarks. Dr. Naveen Thakur is the Director of Deep Children Hospital and Research Center and Adjunct Professor of Pediatrics at Pramushkwami Medical College. He is the President-elect of the International Pediatric Association for the year 2021-2023 and the Secretary of Child Health Foundation. He is a former president of the Asia Pacific Pediatric Association for the year 2016 to 2018 and the national president of the Indian Academy of Pediatrics for the year 2007. Without further ado, to Dr. Thakur, the time and screen is yours.
Thank you so much. Good morning, good afternoon, good evening from wherever you are joining. I welcome you on behalf of President of IPA, Professor Anwar Hassan Gulu, who could not be present today, but on behalf of him, I welcome you all for this very important topic. So we have named it mass epidemic, but all of us who are in clinical practice know very well that it's no more a hidden threat. We are seeing antimicrobial resistance in our practice and how difficult it has become nowadays to deal with the various infection. And I'm so happy that under leadership of our strategic advisory group on infectious disease and AMR, Professor Ashraf Sultan and Professor Mortada, we have organized this webinar. This is just first in series of actions which IPA is going to take to tackle with this. You already know that WHO has released a guideline, a roadmap, and IPA will be working with all the partners. We can do a lot. You know, there is a lot of things we can do as clinician, as pediatrician. Today you will hear from experts what is the magnitude, what can be done, and we have very good best practices example from so many countries, including from my country, India, where Indian Academy of Pediatrics has done so much work on this. So all of us, let's get together, get ready to tackle this menace of antimicrobial resistance and how it is affecting our practice and our future generation, where we may not have any antibiotics, antimicrobial to deal with the microbes. So without any further delay, I will hand over to my moderators of this session, and I welcome you all to come to India for 60th IPA Congress and 30th IPA Congress and 60th Indian Academy of Pediatrics Congress in Gandhinagar. You have seen the banner. Register today and join large number, and there we are definitely going to launch a very well-defined project with timeline and deliverables on antimicrobial resistance. So I look forward to receive your feedback, what can we do, and I hand over to the moderators. Thank you so much.
Thank you, Dr. Thacker, for your inspiring opening remarks. The next agenda of our webinar will be moderated by two very special and distinguished guests. It is my great honor today to introduce our moderators for the session. Professor Muhammad Ashraf Sultan is a director at Mid City Hospital in Lahore, Pakistan. Prior to this, he was a professor and chairman of the Department of Pediatrics, King Edward Medical University, Mayo Hospital, Lahore. Professor Sultan is a member of the Royal Colleges of Physicians and a fellow of the Royal College of Pediatrics and Child Health. Professor Sultan is a supervisor, second fellowship in pediatric infectious disease, College of Physicians and Surgeons, Pakistan. He was also the program director of the Diploma in Child Health and Doctor of Medicine Pediatrics program at King Edward Medical University, Pakistan. Professor Sultan is a member of the National Technical Advisory Group on Immunization and has served as the focal person for the Integrated Management of Childhood Illnesses Strategy Pre-Service Induction Program. Good evening, Professor, and welcome to our webinar. Thank you for taking your time to be with us today. I will now introduce the second moderator of this webinar. Professor Mortada H.F. El-Shabrawi is an emeritus professor of pediatrics at the Faculty of Medicine, Cairo University, where he was also a full professor of pediatrics from 1997 to 2014. He is a fellow of the American Association for the Study of Liver Disease, a member of several international associations or societies in pediatrics and hepatology, including the International Pediatric Association, European Association for the Study of the Liver, and the International Society of Tropical Pediatrics. With his extensive experience and contribution to child health in Egypt and across the globe, Professor El-Shabrawi has been awarded several awards, including the Cairo University Award of Appreciation in Medical Sciences in 2010 and the Cairo University Award of Distinction in Medical Sciences in 2018. And now to Professor El-Shabrawi, the time and screen is yours.
Hello, everybody. Good morning, good afternoon, good evening, wherever you are in the world. I am very honored and pleased to be moderating this very important webinar. As Professor Thacker said, this topic is very, very important and is one of the important topics of the 21st century, the antimicrobial resistance. We are in the IPA, the International Pediatric Association, and particularly in the Strategic Advisory Group on Antimicrobial Resistance and Infectious Diseases concerned with the antimicrobial resistance. And we have two distinguished speakers in this webinar who enlighten us on the antimicrobial resistance in pediatrics as well as neonatology. I have the pleasure and honor to introduce without further delay the first speaker, a longtime friend of mine and of Egypt, Professor Michael Brady. He is now a professor of pediatrics at the Ohio State University, but he has been very active for more than 39 years in the field of infectious diseases in pediatrics. He has contributed a lot to various infectious diseases, particularly HIV and other infections, and he has contributed to the publications by the American Academy of Pediatrics and many other societies on infectious diseases, particularly the Red Book. Professor Brady has been co-editor and editor of the Red Book for many years, and now we are very happy to listen to his presentation. Professor Brady, please.
Well, Mutada, thank you for the introduction. And I hope that I can give you some kind of understanding of the importance of addressing antimicrobial resistance. Can I have the next slide, please? So we have had issues with infections for centuries. And the first attempts to try to address those were poultices made from herbs, and they probably did have some antimicrobial activities. However, it wasn't until 1928 when Alexander Fleming identified the antimicrobial effect of penicillin that we had a true kind of antibiotic. However, it was very clear that resistance occurs actually more quickly than we would like. Penicillin was first commercially available in 1941. And by 1942, there was evidence of resistance by Staph aureus. 1967 with Streptococcus pneumoniae, Neisseria gonorrhea in 1976. So you can see that we had a good start to get antibiotics available to people, but very quickly we ran into an issue of resistance. So next slide. So you can see I mentioned that Staph aureus in 1942 is resistant to penicillin. by 1961, kind of the replacement was methicillin and similar antibiotics, and we had resistance. By 1997, we had vancomycin-resistant Staph aureus. 2001, linezolid resistant Staph aureus, and by 2004, we had daptomycin-resistant Staph aureus. So one of the things that's very clear is that resistance is a continuing process, and that it occurs even though we continue to develop additional antibiotics to try to address resistance. Next slide, please. So the World Health Organization has made a few statements that I think are important for us to understand, and I think many on this conference call or this webinar will already be aware. Antibiotic resistance is one of the biggest threats to global health, to food security, and development. Antibiotic resistance can affect anyone of any age in any country. And as pediatricians, we're obviously very interested in the impact on children. Antibiotic resistance actually does occur naturally, but misuse of antibiotics in humans and animals has accelerated the process. And we've had a number of infections which are now much more difficult to manage and treat, such as pneumonia, tuberculosis, gonorrhea, salmonellosis, because of antibiotic and antimicrobial resistance. And antibiotic resistance leads to longer hospital stays, higher medical costs, and increase in mortality. Next slide, please. So again, some additional facts from the World Health Organization. We now see that antibiotic resistance is at dangerously high levels in all parts of the world. No part of the world is spared. There are additional new resistant mechanisms that are emerging constantly. And we need to understand that in countries without standard treatment guidelines, antibiotics are often overprescribed by health workers and veterinarians and overused by the public. Next slide, please. So when you take a look at deaths, the World Health Organization has kind of identified the fact that by 2050, antibiotic resistance related deaths will be about 10 million. And you can see, compared to things like cancer and diabetes, et cetera, it's going to exceed those, which are very, very impactful conditions. But you'll see that if we don't do something about antimicrobial resistance, this particular problem will exceed even those particular conditions. Next slide. And right now, by 2050, there's an expectation that about every 3 seconds that somebody will die from an antibiotic resistant infection. Next slide. So when you look at the mechanism of action of antibiotics, you can see that they impact the microorganisms at the cell wall level, cell membrane, nucleic acid synthesis, protein synthesis, and folic acid metabolism. So they can have a broad range of opportunities for impacting the microorganisms that we're trying to kill. But the bacteria have learned how to modify some of these areas, such as the cell wall, cell membrane, synthesis of nucleic acids, protein synthesis, and folic acid metabolism. Next slide, please. So this is just kind of a schematic of some of the different issues that we have to identify as possible mechanisms for the resistance of antimicrobial agents for bacterial infections. And you can see that the bacteria really take advantage of every opportunity that they can to try to interfere with the actions of the antibiotics that we are using. And unfortunately, these attempts occur sometimes relatively quickly and sometimes make certain classes of antibiotics almost not effective very quickly. So what are the mechanisms of antibiotic resistance? Well, as I mentioned, there's a number of different antimicrobial targets of antibiotics. And there are then modifications by the bacteria, which can reduce the ability for the organism to be impacted by our antibiotics. There are things like decreasing the affinity for the drug through transduction, transformation, and mutations. There are ways for the bacteria to decrease the drug uptake by the particular bacteria by decreased binding or altered permeability of the cell wall or cell membrane. In addition, the bacteria have developed mechanisms for actually sending the antibiotic that has been given to the patient from the inside of the bacteria and send it outside so it no longer can be harmful. And these are things that are continually changing, and we need to be aware of the fact that as we pressure the bacteria to with antibiotics, that one of the problems we're going to run into is that they are going to develop mechanisms for evading the antibiotics. And unfortunately, they're doing it at a fairly significant pace that we need to keep up with. Next slide. So again, this is another schematic that just kind of shows how the kind of bacteria and fungi fight back against antibiotics. And as I mentioned, this has been occurring, and we'll talk a little bit about what are some of the things that are pressuring these changes in the bacteria. Next slide, please. So again, these are different mechanisms, and these are things where not only can the individual bacteria result in changes in the bacteria, they also can share these changes. So if there are certain components within a bacteria that has resulted in antimicrobial resistance, it not only can affect the ability for the antibiotics to kill the particular organism, that particular organism has opportunities through transduction, conjugation, transformation to actually share the ability for development of resistance. So that's why it has become extremely important for us to understand how we need to kind of circumvent the ability for the organisms to be able to modify, and in order to reduce the susceptibility to our antibiotics. Next slide, please. Next slide, this one. So the global burden of bacterial antimicrobial resistance in 2019, the most frequent antibiotic-resistant pathogens caused deaths globally were Escherichia coli, Staph aureus, Klebsiella pneumoniae, Pseudomonas aeruginosa, Streptococcus pneumoniae, and Acinetobacter baumannii. Next slide, please. So if you look at the global burden, you can see that the major kind of syndromes that are impacted by bacterial resistance, the number one is lower respiratory tract infections, followed by bloodstream infections. And you can see here a number of other infections as you go through the list here. But you can see that the deaths are in the hundreds of thousands, and this is globally, that are directly or indirectly related to the fact that we have pressured the organisms to develop resistance, and that has then impacted our ability to effectively treat these very, very serious infections. And so this is kind of a situation where in 1941, we had the development of penicillin, and in 2022, we have a situation where, despite having large number of effective antibiotics, we have developed a situation where not only do we have antibiotics, but we have significant and harmful antibiotic resistance. Next slide, please. And then if you look at the areas where we're seeing the greatest global burden of antimicrobial resistance and death rates, you can see that unfortunately there are a number of different areas, particularly some of the kind of areas of the world that have least opportunities for having high-level care, et cetera, that have been impacted by the development of antimicrobial resistance. So you can see on the left-hand side that the sub-Saharan areas of Africa are probably the most significantly impacted. And then as you kind of go across there, you can see, unfortunately, there is no area that isn't impacted, but that this is clearly a situation where some of the resource poor countries are kind of bearing the burden of antimicrobial resistance. Next slide, please. So if you look at the kind of crisis with antimicrobial resistance, in Europe, in the European Union, they've estimated that it causes about 25,000 deaths per year and about 2.5 million extra hospital days. In India, in 1 year, as a result of antibiotic resistant infections, they had 58,000 infants die. In Thailand, antibiotic resistance caused about 38,000 deaths and about 3.2 million hospital stays. And in the United States, antibiotic resistance caused about 23,000 deaths and about 2 million illnesses. So as you can see, across the world, this is a very, very impactful situation that we need to address. And this is just another one in the United States with antibiotic resistance. Now, the CDC has come up with a listing, and I'm not going to go through all of them, but they list the situation where they have divided the risk situations by urgent threats and by serious threats. And next slide. Concerning threats, and then a watch list. And you can see that these lists are relatively significant with respect to the numbers of different organisms and the kind of reducing numbers of options that we have in order to manage these bacteria and fungi that are developing antibiotic resistance and representing threats for our patients. And so we need to be very, very clear that this is important. So now, next slide. Whoops, we're not in the right slides. Next slide. Next slide. Next slide. I'm past these. Next slide. Next slide, please. Okay, so some of the causes and transmission of antibiotic resistance bacteria, obviously as clinicians, we bear significant brunt of the reasons why we're having problems, but it's not just limited to overuse or misuse of antibiotics. We also have some issues related to kind of farm and agriculture overuse of antibiotics. And we also have situations where we have antibiotics even in our wastewater that is sometimes used as part of fertilization that can contaminate fruits, vegetables, etc. And these are all different situations where we can either increase the risk of antimicrobial resistance or increase the exposure to antimicrobial resistant organisms. Next slide, please. Okay, so again, this is just another kind of schematic of showing how there's kind of a chain of transmission of antimicrobial resistance. And it is very significant, but understanding this chain will give us the best opportunity to try to interrupt the chain and reduce antimicrobial resistance. So next slide, please. So what do we need to do? First of all, we need to make sure that everybody is aware and understands antimicrobial resistance. This is not just in the medical field. We need to make sure that all individuals are aware. We need to strengthen surveillance and understand better what's going on with research because that's the only way we can target areas where we can reduce the incidence of infection with antimicrobial resistant organisms. We need to optimize the use of antimicrobial medicines. There is no question that overuse or misuse of antibiotics is highly responsible for the problem we're seeing with antimicrobial resistance. And we need to ensure sustainable investment in countering antimicrobial resistance. Okay. Next slide, please. So what we need to do is we need to make sure that the public is aware. And we need to have them understand that when they have some type of a medical problem where it may be an infection, we need to have judicious use of antibiotics and not just respond to requests for an antibiotic. We need to improve hygiene and prevent spread of infections, reduce unnecessary use of antimicrobials in agriculture. We need to improve global surveillance. We need to promote new and rapid diagnostics, which will allow us to understand what the particular infection is more rapidly. And many times it's not a bacterial infection, and therefore we can avoid using antibiotics. We need to promote development of vaccines that will allow us to prevent certain bacterial infections. And that will definitely result then in fewer uses of antibiotics. And we need to make sure that we have adequate funding and adequate coalitions with different areas around the world to make sure that we have the ability to address these problems. See, again, we need to make sure we have better water and sanitation because many times we see situations where poor sanitation results in diarrheal diseases, and they frequently get treated with antibiotics. Individuals only use antibiotics when prescribed by a health professional, and they've identified that countries that have guidelines can reduce their ability to reduce their ability to use antibiotics. Never share leftover antibiotics. Make sure that you try to prevent infections with good hygiene, prepare food hygienically, and choose foods that have been produced without the use of antibiotics. Because if we can do that, we can reduce the transmission of antibiotic resistant organisms within animals. And then healthcare professionals, obviously they need to be hygienic in their activities, only dispense antibiotics when needed, report antibiotic resistance to surveillance teams, talk to your patients about using antibiotics correctly, and also trying to talk to patients about preventing infection. Getting close here to the end. Okay, CDC has created a number of different opportunities for developing antibiotic stewardship programs. We do know that they work. It's very, very important that we address the situation. We can do it kind of basically if that's all the resources that are available. We can then kind of increase until we get to advanced situations. But it's very, very clear that what we need to do is if you have a sick patient, you may need to have an empirical diagnosis, particularly if something is very, very severe and you have very little time. But on the other hand, you want to be able to make the diagnosis quickly. And again, utilization, I didn't keep another slide, please. I'm on slide 31. Whoops. Okay. Go back, please. The back one. There we go. So I'm sorry. So these are different things, but rapid diagnostic testing can lead to the optimal treatment. And so wherever they're made available, you should try to use them. There are a number of panels now for different types of infections. And there are a number of different things that are rapid tests that will detect viruses. And if you know that it's RSV or influenza, you don't need to use antibiotics to treat those, and you may be able to use antivirals, but not antibiotics. Next slide. Okay. And we want to reduce antibiotic use. And we want to, again, address the issue of overuse of antibiotics in the agricultural sector. I did want to also just quickly, say that, all of these things need to be done together. It isn't something just one person can do. It isn't something that just one country can do. This is something that has to be a global effort. And we realize that there are different levels of resources in different countries, but I do think that we can work together. And as clinicians, we have a significant responsibility. One, to make sure that we use antibiotics correctly. Two, that we make sure that hospitals and patients and everybody understands the impact of antimicrobial resistance, and that we all can be part of the situation where we can prevent continued growth of the number of antimicrobial resistant organisms and try to have a definite impact. So I'm sorry I had some issues with advancing the slides, but I would like to thank everybody for inviting me to participate in the webinar, and I later on will be glad to answer questions from the audience. So thank you very much.
Thank you very much, Professor Brady, for a very, very interesting presentation, which covers the topic of antimicrobial resistance from almost all aspects. We have plenty of questions, but probably we'll postpone the questions till the presentation of Dr. Williams. Dr. Ashraf, can you present Dr. Williams?
Hello, thank you, Dr. Murtaza, and good day to everybody. We will continue to unmask this masked epidemic of antimicrobial resistance. And Dr. Brady has emphasized about the magnitude of the problem, but I would take time here to say that the AMR is a complex issue, but this is one of the issues where we pediatricians are part of the problem. We should turn around and we should look into our personal practices and should contribute towards becoming part of the solution. So it's indeed a pleasure for me to introduce our next speaker, Dr. Phoebe Williams. She's a pediatric infectious disease specialist and a senior lecturer in School of Public Health, Faculty of Medicine at the University of Sydney, Australia. Her research is focused on neonatal sepsis and antimicrobial resistance, particularly within the settings of the countries of the limited resources. Dr. Phoebe also works within the policy group of the National Center for Immunization and Research Surveillance, advising policy development of immunization strategy. She coordinates a number of clinical trials in pediatric infectious diseases and is an NHMRC Emerging Leader Fellow. Dr. Phoebe, time and screen is yours, and she will talk about antimicrobial resistance in neonatal sepsis. Thank you.
Thank you so much. And I trust that you can all see my screen. Is that okay? Should I take silence as a yes? Is anyone able to just let me know if you can see my slides okay?
Yes, it is clear, Doctor.
Fantastic, thank you. No, thank you so much for the kind invitation to speak today. And thank you so much, Dr. Brady, for that excellent overview on AMR, and some of our messages will be similar, which I think is actually helpful because it really brings home the important points to everyone. I'd like to first start tonight by acknowledging the traditional owners on the land from which we're all meeting today. I know this is an excellent international forum. I'm dialing in from the land of the Bidjigal and Gadigal people of the Eora Nation in Sydney, Australia. And I want to just pay my respect to elders past, present, and emerging from all the countries that we're dialing in from today. So before we talk about neonates, I thought it would be helpful. I'm just going to move my video so that I can see my slides. I thought it would be helpful to first just look at why children less than 5 years of age are dying worldwide. And as pediatricians, you are all familiar with this from your what you see on the ward every day, but we all work in very different healthcare settings. And I'm very lucky in that I get to work both across, resource rich and resource poor settings in my clinical and research capacity. And so when I'm working in Sydney in Australia, I'm often seeing children that are taking up this tiny burden of disease here. So the size of the box in this graph here shows you the number of children that are dying every year from these particular causes. And the shading of the box shows the progress that we've made since the launch of the Millennium Development Goals in 1990, which have obviously now become the Sustainable Development Goals. And they show you what progress we've made, if any, and sometimes we've made poor progress or little progress. So as you can see here, the biggest causes of death in children are things like lower respiratory tract infections, diarrheal diseases, malaria, and the neonatal period, the first 28 days of your life, is by far the most risky time of your life. So even though I can sometimes be very busy on ward rounds in Australia, treating the children in these boxes that are so small that they don't even get words that fit in them. This is things like, oncology diagnoses and metabolic conditions and congenital problems. The vast majority of children across the world are dying from preventable, treatable causes. And the most dangerous time is the first 28 days of life. When we zoom in a little bit more closely and look at those neonatal deaths in particular, which are highlighted here in the yellow parts of this pie graph, you can see that of these neonatal deaths, a large proportion of them are due to infectious causes. So neonatal tetanus, congenital conditions and intrapartum, and sepsis and meningitis are some of the most common causes. But you can also see here that preterm labor, which, as you all know as pediatricians, is often stimulated from babies from intrauterine infections. So when you put the preterm deliveries, congenital pneumonias, sepsis and meningitis all together, you're seeing that about a third of all neonatal deaths are actually due to infections. And even though there's been quite significant progress in reducing under 5 mortality and even infant mortality, so that's babies less than 12 months of age, since the launch of the Millennium Development Goals, we've really made absolutely no progress at all in reducing neonatal mortality rates. So you can see here the progress over the last few decades in under 5 and infant mortality, which has shown a decline across all wealth quintiles in this paper is based on a low middle income country setting of the Philippines, and really can be extrapolated to many settings that are similar. But we are really making no progress at all in neonatal mortality. So it continues to be seen that the most dangerous time in your life is the first week of your life. So this here shows the disability adjusted life years per 100,000 population across the life course. And so here you've got years down the bottom on the x-axis here, and broken down into a number of days towards the start of the axis here. And as you can see, the first 0 to 6 days of your life are by far the most risky time of your life for sustaining for either mortality or sustaining a complication that might leave you with a lifetime of morbidity, such as complications secondary to neonatal sepsis or meningitis. And as you can see also within this graph, the vast majority of those disability adjusted life years in that first week of life come down to the impact of infections and maternal and neonatal conditions, which are highlighted here in red. So we really need to invest more in improving outcomes for babies in that first month of life, and particularly the first week and the first day of life. And that revolves around not just neonatal sepsis, but obviously improving neonatal care. And we know that by doing that, we would see a 3 to 4-fold return on investment, because as I've just shown, the disability adjusted life years are so significant in the morbidity that's sustained in that first week of life for so many, that by focusing on improving neonatal care, we really can have a significant impact on reducing neonatal morbidity and mortality globally. And this is an excellent slide that is available online from the Lancet Every Newborn series. And this just shows how different the neonatal mortality rates are across different healthcare settings in different continents. And this is why my research is focused in resource-constrained settings, because in Japan, where the neonatal mortality rate is 1 per 1,000 live births, or in America, where it's 3, you can see this graph shows the time that it's going to take for different regions of the world to reach similar neonatal mortality rates. And sub-Saharan Africa, where I undertook my PhD, for example, isn't anticipated to reach that achievement until 2124. And Southeast Asia isn't anticipated to reach that for at least another 50 years. So these inequities, in my mind, are really not something that we should just be allowing to continue to happen. And I think that we need a greater focus on not just newborn health, but also improving outcomes in newborns in different settings across the world. And so Dr. Brady's already Is that my sound, or is that somebody else? Hopefully someone else. I will keep on going, and hopefully you can all hear me okay. But Dr. Brady's already given us a beautiful overview of the historical context of how quickly resistance to antibiotics has emerged over the last few decades. And we've seen this pie graph, which I think is a really powerful reminder of where we're standing at the moment with antimicrobial resistance, which, as we know as clinicians, is something that is already causing us clinical conundrums every day. But really, unless we act quickly and invest in this appropriately, we're going to see deaths from antimicrobial resistance outstrip other common causes like cancer by 2050. And as with many infectious diseases, deaths attributable to AMR are going to be inequitable across the globe. So when you look at the thousands or millions of deaths that are likely to occur due to AMR by 2050, it's regions like Africa and Asia that will sustain the greatest burdens. So what we're seeing already is that multi-drug resistant pathogens and those that harbour extended spectrum beta-lactamases or carbapenemases, as Dr. Brady so beautifully alluded to in his mechanisms of AMR, already account for 1 in 3 of all global neonatal sepsis mortality deaths that are occurring. But neonatal sepsis is a really tricky clinical condition. And one of the hardest things for us as clinicians is knowing when a baby has sepsis or meningitis, because as you all know, the signs of neonatal sepsis really overlap with so many common causes of neonatal, of an unstable infant that you might have in front of you. So there could be a viral illness in the background. There could be congenital heart disease that's causing a baby to have tachypnea rather than sepsis. They could have complications from birth asphyxia. And so there are many, many other differential diagnoses that make diagnosing neonatal sepsis very, very difficult. And when you look at the most common signs and symptoms that present with neonatal sepsis, you can see that many of these cross over with many other conditions that we commonly see in neonates. And so whenever we see an infant and we're thinking of neonatal sepsis, often, appropriately we reach to commence empiric antibiotic therapy. And that's because diagnosing neonatal sepsis is difficult, both from a clinical sign point of view, but also because we don't have great diagnostics. Blood cultures are a very insensitive test and give us information quite slowly, if at all. And so often we're giving broad empiric therapy. And in the background, we need to make sure we also consider other things that could be responsible for the presentation in that infant. So that, as I said, includes viral infections or fungal infections, which we're seeing as an increasing problem in neonatal bloodstream infections, CNS insults or endocrine or cardiorespiratory differential diagnoses. So it's important to not just always immediately start an unstable baby on antibiotics, but to do so if we have any concern about sepsis, but also consider all the differential diagnoses that might be occurring in the background. And so historically, I guess we all learnt in medical school about neonatal sepsis as being something that was divided into early onset and late onset sepsis. And most places have antibiotic guidelines that are guided by those pathogens that we historically have always thought to be responsible for those two times of a baby's life point that they might get invasive infections. So Group B strep and E. coli were traditionally considered the most common causes of early onset sepsis, while E. coli becoming more prominent with late onset sepsis and still some GBS, and then other pathogens like Staph aureus and Klebsiella emerge as children get older, and coagulase negative Staphylococcus could cause a problem in an ex-premature baby that might have been in a NICU for a long time with lots of plastic wear in place. And so because we have those historic pathogens that are responsible, by our textbook teachings as being causing early and late onset sepsis, we have guidelines that have been curated to be directed against those pathogens. And these, I'm sure, are antibiotics that are familiar to many of you. But unfortunately, many sites are not able to use these empiric therapies anymore because we're gradually seeing that most empiric therapies are not working in many of the pathogens that are causing sepsis in babies today. So this was the study that I was involved in, looking at the rates of antimicrobial resistance in children across sub-Saharan Africa. And we found some really concerning rates of resistance in babies for both sepsis and meningitis, with gram-negative pathogens having high rates of resistance to both first and second generation second-line therapy in that setting, as well as resistance for many of the other common pathogens causing sepsis and meningitis in young babies. And as Dr. Brady alluded to, this means that we've got many thousands of children dying in many areas of the world every year unnecessarily, just due to failure of our current empirical therapies to work. And while Dr. Brady pointed out that that includes 60,000 babies in India alone that are dying every year from AMR, the other really important thing to note from this paper and from this graph is that we're really starting to see gram-negative pathogens outstrip gram-positive pathogens in causing deaths due to AMR. So I'll skip over these because it's been covered so nicely by Dr. Brady, but just to again bring home the point that antimicrobial resistance is not something that's affecting the world equally, and the greatest numbers of deaths are occurring in the most resource constrained areas of the world. And AMR therefore results in high neonatal mortality rates in low and middle income countries due to a number of reasons. First of all, they have a higher baseline burden of infectious diseases. So we know that the incidence of neonatal sepsis, even antimicrobial susceptible in neonatal sepsis, is 10 times higher in resource constrained settings than in resource rich countries. These tend to be settings that have weaker healthcare systems, with overcrowding being quite common. And because of overcrowding, you see gram-negative organisms predominate, and particularly outbreaks of gram-negative organisms are quite common in many of these settings. And then once there are outbreaks of these multi-drug resistant pathogens, there's often insufficient access to effective antibiotics in many of these settings. And so we now know that up to 50% of the common isolates from healthcare facilities in low and middle income countries will be resistant to what are the current WHO recommended first-line antibiotics. So importantly, we are, as I said, seeing a greater and greater burden of deaths attributable to gram-negative pathogens. So E. coli and Klebsiella are starting to take quite significant prominence, along with MRSA, deaths due to MRSA, which are implicated in Staphylococcus aureus infections. And as Dr. Brady alluded to as well, going through this paper, bloodstream infections, which is of particular importance for neonates, are the second most common cause of death due to antimicrobial resistance worldwide. And when we look at which pathogens cause the most deaths by absolute numbers, again, you can see that some gram-negative organisms in particular are responsible for a huge number of deaths. So Acinetobacter baumannii, E. coli and Klebsiella pneumoniae, I think together cause the biggest problem for neonatal intensive care units worldwide at the moment. So that leads us to really start to think if this historical teaching that we've had of early onset and late onset sepsis and the pathogens being responsible for EOS and LOS are actually still relevant today. And I think it's time that we started in the context of how high rates of antimicrobial resistance are. I think it's time that we started to realize that many of our empirical therapies might not be appropriate because the pathogens really have come a long way since those traditional teachings in medical school. So this was an excellent study that looked at many centers that I'm sure many of you on this call were involved in, that looked at the pathogens responsible for neonatal sepsis across many centers in India, and found that really the distribution of the pathogens didn't vary significantly between those, previously defined early onset periods of the first 48 or 72 hours of life versus late onset periods. And most importantly, you can see that, as I said, Acinetobacter and Klebsiella were responsible for a large number of deaths across that early period of life. And then the Barnard study has also recently been published, which again showed that the vast majority of neonatal sepsis isolates were due to multi-drug resistant gram-negative organisms, with many of the pathogens isolated in this study resistant to at least one beta-lactam and one aminoglycoside. So again, indicating that our current WHO empirical therapies are probably not efficacious anymore in the context of growing AMR. And the NEO-AMR network also did an excellent review from a number of neonatal intensive care units over the last couple of years that revealed, again, very, very high rates of gram-negative resistance to third-generation cephalosporins and carbapenems. As you can see in Bangladesh, 84% of gram-negative organisms were resistant to third-generation cephalosporins and 80% resistant to carbapenems. So very, very high rates in some healthcare settings. And we know that AMR is a risk factor for neonatal mortality. So this was a lovely paper that looked at death due to multi-drug resistant pathogens in babies in Vietnam. And they found that because of the delay that typically occurs in hospital-acquired infections with babies that have multi-drug infections, that there is often a higher case fatality rate in those infants. And the authors concluded that the absence of effective drugs contributes to the increased mortality seen in their neonatal cohort, and empiric therapy might fail due to antibiotic resistance. And all this occurs in a really slow and dry antibiotic pipeline. So as both Dr. Brady and myself have shown, we really see evolution of antibiotic resistance quite quickly once new antibiotics are discovered. But what we know now is that the rate of AMR that's developing globally is not keeping up with the rate of new drug discovery. And even more importantly, the new drug discovery pipeline for children and particularly for neonates is nothing compared to what is on the radar for adults. So these two graphs here are part of a publication that will soon come out that I have authored with a number of authors across the world that has looked at the number of clinical trials for new antibiotics that are currently being conducted. And in yellow here, you can see the number of trials happening in adults. In orange, you can see the number of trials happening in children. And this tiny slice here are the number of trials happening for new antibiotics that might be relevant for use in neonates. And similarly, when we look back at how many new antibiotics have been approved for use in neonates, you can see that while there have been 40 antibiotics approved for adults since the year 2000, only 5 have been approved for children and only 3 for neonates. So the current landscape of funding and research and development to look at antimicrobial resistance really globally is inadequate, but particularly for children is really vastly inadequate for the burden of death that AMR is currently causing for neonates. And there are many strategies, though, that are looking to address this, and most importantly, to try and actually just get some of this burden out there into the literature. So I've presented some of the recent publications today, and I'm also very lucky to lead a collaboration called NeoSeq that is trying to better ascertain what the rates of antimicrobial resistance are across the Southeast Asia and Pacific area, which are really areas where we know from a clinical point of view that there are many very difficult gram-negative hospital-acquired infection outbreaks occurring in many of these neonatal intensive care units. But there's just not enough global attention on working to find solutions for those outbreaks and better drugs to reduce the morbidity and mortality that they're causing. So what we anticipate will happen over the next 5 to 10 years is there will be some big clinical trials that will look to see if we can come up with better empirical therapies that are better targeted to improve the outcomes for children that have sepsis, so that we can ensure that in regions of the world where we know that antimicrobial resistance is high, that we can be giving those infants treatments that are likely to be efficacious for the epidemiology that is causing infections for them locally. And before I finish, there was just one last point I wanted to make. I've talked a lot today about, the burden of antimicrobial resistance and the problems with our empirical therapy and overprescribing in many instances, and often jumping to too broad spectrum of therapy if we're worried that empirical therapy might not be efficacious. But I think it's also worth bearing in mind as we finish this webinar that there are many children that are actually also dying at the same time due to a lack of access to any antibiotics. So we know that a lack of access to simple antibiotics like penicillin or amoxicillin is currently causing many thousands of deaths due to pneumonia in children worldwide. And so we need to really try and strike that balance to find to ensure that we don't overprescribe and overuse antibiotics and see AMR become more of a problem. And by the same token, we also need to make sure that children everywhere who need antibiotics are appropriately diagnosed and treated and receive that antibiotic course that they need. So thank you so much for your time and attention today. I think there are a few people on the call today from Indonesia, and this is a recent site visit I did to a fantastic hospital in Bandung, and their incredible infection prevention and control team that are working very, very hard to address antimicrobial resistance there. And I look forward to taking your questions.
Okay, thank you very much, Dr. Phoebe, for an excellent presentation and highlighting the magnitude of AMR as a significant factor in the high neonatal mortality, and also emphasizing on investment in development of newer antibiotics, because there aren't many in the pipeline. Thank you very much. And now I hand over the mic to Murtada for question and answer, which are addressed to Dr. Michael Brady. Thank you.
Hello? Mortada, I think you're muted. I can't.
Yes, please. Yeah, I'm muted now. Thank you very much, Phoebe. Thank you very much, Mike, for two very interesting talks. And I think by the end of these two talks, we have seen the magnitude of the problem of antimicrobial resistance at any age, at any country, anywhere in the world. Before the webinar, we had lots of questions from registrants on the different geographic distribution of antimicrobial resistance. And I think, Mike, although you have covered it, but we need a sum up of the geographic distribution of antimicrobial resistance, because we had lots of questions from Sub-Saharan Africa, from West Africa, from the Middle East, from Southeast Asia. You covered lots of these points, but please, can you sum up the magnitude of the geographic distribution of antimicrobial resistance at the first question?
Okay. So can everybody hear me?
Yes.
Okay. So as I mentioned, antimicrobial resistance is worldwide. And one of the situations that I think is very, very important to understand is, and as Phoebe mentioned, there are two issues here. One is access to adequate care, and that is receiving appropriate antibiotics. And then the other situation is the impact of antimicrobial resistance, which will then lead to potentially failures of treatment And one of the things that is I think very clear is that resource poor countries are more likely to have more of a significant impact of antimicrobial resistance. One, because they are having issues with increasing numbers of antimicrobial resistance, but also because they may or may not be capable of managing the infants with the technology that's available in many of the countries that have much greater resources. So as was mentioned, when you look at kind of where the disease burden is related to antimicrobial resistance, it looks like sub-Saharan Africa is probably the greatest impact, and then Southern Asia are the areas where we see more clinical disease related to antimicrobial resistance, as well as deaths. Now, that doesn't necessarily mean that it's not happening around the rest of the world. But again, I think that like many situations where it comes to healthcare, resource poor countries are the ones that are bearing much of the burden. So it's a global problem. It is impacting resource poor countries, particularly sub-Saharan Africa, as well as Southern and Southeastern Asia. And I think that, you know, resource countries need to understand that they need to start to work on changing that situation. And then the other thing that Phoebe mentioned is we aren't having the development of newer antibiotics that would be capable of managing antimicrobial resistance. And even if we do get those, their ability to kind of make their way into the resource poor countries is going to be obviously slower. And I think those are things that we can't allow to happen. The world needs to get together and make sure that we develop practices that are going to reduce antimicrobial resistance, but also make sure that we can provide to resource poor countries the resources that they're going to need in order to address it.
Thank you, Mike. There's another question from India. How can we end the antimicrobial resistance pandemic? How can they end the pandemic?
Okay, so there's a lot of things that we can do. The first thing we need to do is make sure that everybody kind of is aware of the problem of antimicrobial resistance. It's unlikely we're going to get people who can make the difference, whether it be the health kind of associations, kind of like International Pediatric Association, to get involved if they aren't aware. So we have to kind of trumpet the fact that we have this issue. But then I went over a lot of different things, and some of them, things like water sanitation, is something that would be valuable not only to prevent antimicrobial resistance, but just the general health and well-being. We need to work on that. We need to kind of work on strategies to try to ensure that antibiotics are not used inappropriately, which means, again, helping countries develop the resources to do rapid diagnostics so they can sometimes avoid using antibiotics, particularly if things like viral infections are identified more rapidly. I think that we need to continue to address the fact that a tremendous amount of antibiotic resistance is occurring in agriculture, and that, again, is something that may be more problematic in some of the resource poor countries, but it's something that has to be addressed. And then I think we have to address the fact that many times healthcare settings are kind of the location where a lot of this antimicrobial resistance is developing, and we need to have strategies. And again, they may be different in resource poor countries rather than in other areas, but they are equally necessary.
Another question from Nigeria, Mike. They are asking, how can we overcome the problem of indiscriminate access to antibiotics and at the same time lack of effective antibiotics? How can they overcome this in Nigeria?
Well, I think that, so first of all, much of the overuse or misuse of antibiotics is being done in the healthcare setting. And that's something that is true all across the world. The other situation, though, is there are many places where it's easy to get antibiotics without even a physician's prescription. And I think that that is something else that also has to be addressed, is that we can't just indiscriminately allow access to antibiotics in settings where they may not be appropriate. So I think we need to kind of work on education of not only physicians, but also the general population about the value of antibiotics, but the potential harms of misuse of antibiotics. The other thing that I think is very important is that Phoebe mentioned that when it comes to children, and particularly she was discussing the issue of neonates, there just isn't an adequate amount of investment in trying to figure out how to get more and more antibiotics adequately studied and then available for use in pediatric patients. And, you know, I think that a combination of appropriate access, so as was mentioned, some children die, not just from antimicrobial resistance, but also from lack of receiving antibiotics. But in addition to that, trying to make sure that it is used appropriately.
Thank you, Mike. I think the discussion can go for hours and hours, but I believe for sake of time, I'll just jump to the last question, which is a very clever question. What do you advise the young pediatrician, either in office or in hospital, to do in order to avoid developing antimicrobial resistance for his kids?
Well, you know, as I mentioned, I do think that clinicians are the ones who can have a significant impact. One is to address the fact that all too frequently, when families come to a physician and they're having a problem, they like to do something. And in many times, the particular condition may not need an antibiotic. And I think that we need to be able to teach clinicians that it's very important to judiciously use antibiotics. And that means don't use antibiotics if they aren't adequately identified as being needed. I can tell you in the United States, one of the biggest problems that we have is overuse of treatment of children for the diagnosis of otitis media, which they've identified is not frequently there when the antibiotics are given. And so I think that the clinicians need to be aware of the fact that they need to establish the correct diagnosis and only give antibiotics when necessary, and not to respond to parents' requests for antibiotics if they aren't needed.
Thank you very much, Mike. And I think we have to stop there for sake of time. And I thank all the participants for their very valuable questions, and probably they might be answered by email later on. I'll send the microphone to Dr. Sultan. Dr. Sultan?
Yeah, thank you, Murtada. I think there could be some overlap of questions if the subject is the same. There is first question for Dr. Phoebe that what's the pattern of gentimizing resistance among neonate in developed and developing countries? And I'll club another question from Saudi Arabia with that is this the time to change neonatal septic empirical therapy practices?
Thank you for that. So aminoglycosides are actually one of the few classes that have retained some susceptibility, not uniformly, but certainly there are some aminoglycosides that still have quite good susceptibility profiles for gram-negative pathogens in many settings of the world. In terms of, the current empirical therapies, I think we're at a really similar to the sort of access and excess equation. I think we're at a bit of a tricky time in terms of knowing what to prescribe as an empiric therapy for our neonates as well. And I really think that comes down to a different empirical regime for every intensive care unit. What I would try and advise against is having a broad spectrum antibiotic as your unit's empirical therapy. The Neo-AMR network have done a very nice point prevalence prescribing survey that has looked at what different NICUs are using as their first line therapy. And many units are using things like carbapenems or amsulbactam or pip/tazo as their first line therapy for neonatal sepsis. And by using such broad spectrum therapies, you then very quickly put selection pressure on the pathogens that might be being harbored within that intensive care unit. And very quickly, you then see resistance to even those broad spectrum therapies emerge. So then you end up with, outbreaks of multi-drug resistant Acinetobacter baumannii infections or carbapenem resistant Enterobacterales. And so while we need to bear in mind that ampicillin and gentamicin might not be necessarily the most appropriate first-line therapy for your unit based on your local antibiograms. For many settings, it still is. So in Australia, we absolutely use AMP and Gent as our first-line therapy for neonatal sepsis because you do want to keep prescribing as narrow as can be. But what we really need is we need a good worldwide picture of the data to understand what the pathogens are causing neonatal sepsis in each country and in different healthcare settings in different countries, because urban is very different to rural settings and community-acquired infections are very different to hospital-acquired infections. And once we have that good baseline demographic data, then it's time to look at revising the WHO empirical therapy guidelines so that empirical therapy can be targeted to patterns of resistance that we see in specific regions of the world. And that will happen over the next 5 to 10 years. So there's GARD-P, for example, have a big platform trial that is anticipated to start recruiting over the next couple of years that, again, many of you might be involved in as sites, that is looking at different new empirical regimes using agents like amikacin, fosfomycin, colistin, and also some of the newer antibiotics, like cafetericol, and comparing which of those agents have best outcomes for many of those neonates. And I think that as that data is gradually accumulated, we will see a change in the WHO guidelines. But for the time being, the best thing to do is to stay as narrow as possible, but bearing in mind your local antibiogram.
Okay, thank you. There are two questions from Indonesia, that how to avoid misuse of antimicrobial. And the second question is that since we do not have facilities of microbial resistance test in our clinic, what is the solution?
Very, very difficult. And I think the solution is that we need to make sure that access to diagnostics and efficacious therapy where AMR is a problem is more equitable worldwide. I think there are a few, good platforms to try and improve access to diagnostics. So the Fleming Fund, for example, and the Wellcome Trust are working really hard on trying to make sure that, labs across the world has just even a basic, strategy, even sometimes with just mobile labs, to be able to enhance the diagnosis of neonatal sepsis. But even with labs in place, as I said in my talk, a blood culture is a very insensitive test that often doesn't give us much information. So we need more research and development into better diagnostics, looking at sort of potentially PCR-based tools or other ways that we can better diagnose neonatal sepsis, because that will allow us to use our antibiotics more judiciously, and ensure that we're not over-prescribing, but also ensure that we're not missing cases of neonatal sepsis and contributing to that huge morbidity and mortality burden that I showed in some of those graphs earlier.
Okay, thank you. Since we are running short of time, I'll just ask one last question, and we need a quick response. That is, would probiotic use reduce AMR issue?
Yeah, that's an excellent question. I think there is some good and emerging evidence that probiotics might reduce the rates of neonatal sepsis, not necessarily AMR, but if you can reduce sepsis, you can therefore hopefully reduce the proportion of that sepsis that's due to multi-drug resistant pathogens too. I know there are a few good studies that are still recruiting, and there have also been some previously published papers showing that specific probiotics might reduce rates of neonatal sepsis, but it might be confined to specific populations, and we know that some probiotics can even have adverse events in some populations, like significantly immunosuppressed patients. So I think that's a really good question, and certainly an emerging field, but one that we need to gather a little more data on before we conclusively say that probiotics reduce neonatal sepsis and which probiotics work.
Okay, thank you very much, Dr. Phoebe and Dr. Brady. And I would now hand over the mic to the admin. Thank you very much for being part of this webinar.
Of course, no event is complete without the photo session. We now invite once again our honorable speakers, guests, and moderators to turn your videos on as we take the group photo. And to all the participants, kindly turn your videos on as well, as we will take a group photo with all our distinguished speakers and moderators. Let us give a few seconds to wait for everyone to turn their videos on. 3, 2, 1. 3, 2, 1. And we'll now be taking the photos. 3, 2, 1. 3, 2, 1. We're in one slide. 3, 2, 1. And once again, on behalf of the organizing committee, we would like to extend our warmest round of gratitude and appreciation to all our speakers, moderators, and participants for making the international webinar on mass epidemic of antimicrobial resistance a great success. To all the participants, kindly fill in the feedback form as detailed on the slides and has been sent via the Zoom and YouTube chat. The certificate of attendance will be shared via email upon completion of the feedback form. Furthermore, the International Pediatric Association also conducts routine webinars with a wide range of topics concerning child health. To keep yourselves up to date, we urge you to follow IPA on our social media platforms as detailed on the slide. We also have several opportunities for you to participate in IPA webinar and activities. First, IPA will be having the IPA Congress next year in 2023. For more details, log on to www.ipa2023congress.org. IPA also provides opportunities for healthcare workers to enroll in the IPA Vaccine Trust course to become a certified vaccine champion. The course is open to all healthcare workers for free. Kindly refer to the post and the IPA website for more information.
Sorry.
We also have an upcoming webinar from the IPA Subcommittee on Education and Advocacy monthly webinar series with the topic Tips on Child Environmental Health for the Practitioner on the 22nd of July, 2022. This webinar is exclusively for pediatricians, doctors, and healthcare professionals. Stay tuned to the IPA social media for more information regarding this webinar. Once again, warmest round of gratitude to all parties who have made this webinar a great success. Thank you, and we hope to see you at the next webinar.